I had a really interesting case recently where a woman presented with a locked knee, meaning a knee that was missing moderate range of motion, was very painful, and therefore walking and daily function was very disturbed. So I'll go through my thought process as I did the verbal history and took the baselines and talk about our patient care episode over 3 visits. And forgive me if I have to look at my notes, but I don't remember everything exactly perfectly. But this was the 4th time this woman reported having an acute locking with pain in her knee. The first time had occurred over 10 years ago. She attributed that, or at least related that, to getting out of a car. This second time was in 2019, and she related that to upon rising from a couch. And so I asked what kind of couch, if she could recall, and she said, yeah, it was a deep, sinky couch, which turned into going to urgent care, getting crutches, getting x-rays, which were negative. The 3rd episode, she didn't remember too many details around that a few years ago. And then this 4th episode, the one that she presented to me regarding, had happened a few days ago, and she was driving and her knee locked up, became very, very painful. So I had seen her about 4 days since the initial episode, and it was getting better, but it was still there. So what I asked is exactly where the pain was, and it was on the posterior left knee predominantly. And then of course, because I asked about all symptoms, I asked about other symptoms in the extremity, other extremity or back, and she said, yes, she'd also noticed some left back pain that was mild. She attributed it to compensating, which is my least favorite word in orthopedics. She attributed it to compensating, and in her mind, they were unrelated, but it's my job to ask these questions and to understand if there can be a possible relationship. So if we go into the mechanical exam, my first baseline is that she's limping. She couldn't put weight on that knee very well. She was walking independently, and she was also leaning forward at her spine, which is not something you would exactly think of with just a knee problem. A limp, yes, but maybe not flexing forward at the spine. Now, let me go back to where my thought process was in terms of just her verbal history. So her knee clearly doesn't move well. So do I think it's possible that there's something mechanical in the knee joint? Absolutely, absolutely. Do I think from her telling me that her history was it seemed to present getting out of deep surfaces, which to me is a lot of stress on the lumbar spine and flexion, and a very benign force on the knee to just be seated, right? It's not a trauma, it's not an extreme position of the knee, it's in about 90 degrees of flexion with seated or with sitting. And cars and deep sinky couches are more lumbar flexion than the traditional hard chair, for example. So am I thinking it could be her spine when I talk to her? Yes. Now, if we get into what is the theory behind a spinal joint misbehaving, a derangement in the low back, causing a knee to lose motion, I don't have great answers for that. I've seen it before. I've pondered this question with colleagues, and I can't give a great anatomical or physiological reason about what is actually occurring to cause that knee to become obstructed, even to passive movement, obstructed to passive movement. But I will say, in lieu of a good explanation, I can use these analogies such that, you know, the foundation of the house isn't moving well, things can misbehave, or things can have problems on the 2nd, 3rd, 4th, 10th floor. So I just think of the body, when I think of the body, I think of the spine as being foundational, and I know people disagree and they think the feet are foundational, and we can get into those interesting debates. But if the feet are foundational because we're on our feet a lot, but we're not on our feet a lot, we're on our pelvis a lot, we're putting our back in a lot of flexion with seated, then the back for the modern day person in America seems more like their back would be their foundation. But I argue the back is also the foundation, or the spine is also the foundation, simply because the nerves that control the extremities emanate from the spine, which originated in the brain, came down through the spinal cord, and then enter at each vertebral level through the neural foramina to the extremities. Anyway, I'm getting off topic. So going back to the verbal history, do I think there's a knee tendon problem? No. Tendons are outside the joint. they wouldn't cause a locking problem, and they wouldn't really be injured with benign things like rising from sitting or being in a car. Could it be something else? Yes. I mean, again, I'm putting lots and lots of different diagnoses that take up 1, 2, 5% of possibilities in a big bucket. But there's no red flags that jump out at me. This has happened before. This is episodic. This is the 4th time in about 15 years. And it resolved in the past. She was concerned because this time it wasn't resolving as much as she has seen in the past in terms of how quickly it resolved. But yeah, there's nothing major in my head when I'm thinking about that other group for her. I'm thinking this is probably a knee joint or a spinal joint. So going back to the baselines, limping, flexing the spine with limping, that tips me off a little bit more to, okay, this could be the spine. She can't straighten up her spine very well when she walks. Or of course that limping could indicate a knee joint problem. Now, I did some spine mobility testing. I thought it was a very good place to start with her. And she had no loss into flexion. She had moderate loss into spine extension. So spine extension, moderate loss. And it was hard for me to test side glide in standing because she couldn't bear weight equally left to right. But I thought it was kind of missing at least a little bit of range of motion, left and right, but kind of inconclusive. But the spine loss into extension was quite obvious to see, especially considering she could touch her toes and achieve quite a bit of flexion, which is what I want to see. Now, on the plinth, on the table, her knee range of motion was quite lacking. I put about a 20-degree loss of extension, actively and passively, and I wasn't going to push it due to pain, and a small 10 or 20-degree loss of passive flexion. So spine, knee range of motion loss into flexion and extension. So that's making me think knee, the spine motion loss is making me think it could also possibly be a spine joint causing these problems. I've seen it before. So I did give her a lumbar roll in sitting to assess the effect. It did not miraculously take her knee pain away at the time because the knee is pretty painless at rest, but she did like the position and the feeling of spine extension with the lumbar roll in sitting. I didn't do any special tests of the knee. I didn't do any other tests really than those. It's very straightforward at this point because I'm really considering that it's a knee joint derangement or a spinal joint derangement. I'm not thinking there's a high likelihood of something other than those two main diagnoses. Again, those are diagnoses that are used by MDT clinicians who understand Robin McKenzie's theory that joints can mechanically get tweaked or deranged. And then, oftentimes they'll work themselves out before patients present to any clinic. They just get better because of general movement. But when they don't respond to time or general movement of the joint, then we look for, is there a directional preference that will get that joint moving well again? So I had her go prone, which is mild lumbar extension, and then prone on elbows. And I did notice that when she was prone, her knees seemed to extend more. Harder to measure in that position for sure, but it looked nicer into a straighter leg, straighter knee in prone and prone on elbows. I had her do about 2 sets of 5 full lumbar extensions in lying. And then when she got up, I had her do some extension in standing over a chair for that additional overpressure with the fulcrum of the chair. And then I tested walking, and it was better. And I had her walk in the hall, and I just observed and I asked, does this feel better? Does it feel worse? Does it feel the same? But it was obvious to me visually that she was walking better, and to her as well, and the pain was less. And then I retested knee range of motion in supine, as I had with taking the baselines, and the extension of the knee was better, not 100%, but better. And her side glides, with her being able to weight bear a little bit better, seemed better. But we only did 1 round of tests. My job as a clinician is to see from the verbal history, from the baseline taking, right? So better with spine movements was a baseline of our, or kind of a outcome of our initial testing. Was this worth her time and energy and money ultimately to do over several days at home? So I talked a lot about posture and how our back tends to flex more in in the lumbar spine with deep sinky couches versus hard chairs. We talked a lot about car seat wedges for the car to take out that sloped bucket seat and relieve some pressure on the lumbar spine and flexion there. And I asked her to do extension either of the lumbar spine in standing or in lying at least 6 times a day. And then we revisited each other a week later. A week later, she presented back to my office. She had been doing the extension in standing exclusively, not in lying. She had also done some side gliding and standing because she liked that. That was not prescribed, but that was pretty innocuous, so that was fine. She noticed her knee was cracking more, but her knee, she reported, was 90% better. And she had some brief intermittent left low back pain still. She had been very diligent and had not been sitting on her couch and had been sitting in her living room in a hard chair. And she planned to kind of do something to remedy that sinky nature of her couch to make it a little bit less deep when you sit into it. So 90% better is great. People will ask, well, could it just be time? And the answer is yes, it could just be time, right? And there's kind of ways to figure it out. I could flex her low back for a week and see if she got worse, or at least for a couple of minutes. But I'm always curious about natural history. Most patients are coming to me after natural history has failed to resolve the problem. I'm usually seeing people after symptoms for many, many weeks or months or years. This case was a little bit more of an aberration because the pain was only 4 days old, but she wasn't thinking it was just time. She attributed some of the change to including more lumbar extension in her day and reducing the amount of severe lumbar flexion in her day. So importantly, when I tested her knee in supine, the range of motion was good. It was normal. It moved just as well as the other side without pain. When I tested her spine, her flexion was still good. She had an improvement in her range of motion and lumbar extension and standing. I put minimal loss versus moderate loss. And left side glide was no loss with no pain, but right side glide gave her a little bit of left low back pain. So there was still something in that joint not moving perfectly because her range of motion wasn't pain-free. And I would say also it wasn't moving 100%, but making that determination about what 100% of movement for this particular patient is hard, right? It's hard to say you have full range of motion out of the get-go. We have to assess, because if repeated movement testing bears out that we can get more motion, then we can conclude that initially range of motion was lacking. So I use that testing, that cause and effect, to kind of figure out if where the person is that person's normal, or if it's on the low end and we can achieve more. So we talked more about postural support. We did extension standing and extension lying, and that did improve the sensation of pain with a right side glide of the lumbar spine and standing. So I said we could reduce the frequency a little bit of the extension and standing and really try to get some of that extension in lying throughout the day, at least twice, and returning to the gym with lighter intensity in terms of weights and activities, especially with lumbar spine loading and squatting. But lighter return to the gym was indicated with extensions right before and after the workout. I saw her about a week later. She said she'd returned to the gym full time. The cracking in her knee was going away. She added more of these exercises pre-workout. She has slowly increased the weight at the gym with the squats and deadlifts. She had added a board under her couch cushions to increase the firmness of her sitting area, and range of motion in the spine I put as full in all planes. She had some mild low back pain with extension. Her knee was still looking great. We reviewed the exercises. I said her homework would be to taper them, but to use them as needed. She wasn't concerned about that mild stuff in her low back when we moved it, and I think she saw the trajectory of it getting better. So I said to decrease the frequency of the exercises as she was able to tolerate. She's not the type of patient where we need to keep on this at a high frequency for many, many weeks or months because of the acute nature of this. She understood the principles very well. She understood the difference between sitting on a sinky surface and doing some extension, the car seat and getting out of the car seat, and how that correlated with the knee problem. So a very successful case. I will follow up with her in a month just to make sure everything is going well. but she kind of understood, hey, if I do all these flexion activities at the gym with squats and deadlifts and sit-ups, etc., and I sit in a sinky couch and I bend over thousands of times a day like an average human in the United States, and I never go back, I'm not creating balance in my spine. So she understood that adding some balance by doing some lumbar extension once, twice, 3 times a day, or only on the days where she does the gym workout, was a meaningful plan that she could incorporate into her life. And she felt more comfortable understanding that there seemed to be a strong relationship between the lumbar spine and her knee. So when or if this knee locks again, she has a plan about what she can do to relieve it on her own without A, being worried or anxious, and B, having to seek medical care. So again, I can't really go through how something in the left lower back or central lower back getting tweaked can create that knee locking. We obviously see pain a lot referred to the extremities, but that range of motion being so profoundly lost in the extremity is interesting to see, especially when it's in the knee versus the hip, which I see more often. I've never really seen a major loss of motion or a moderate loss of motion in the ankle be related to a lumbar joint derangement, but this is the second time that I remember seeing it quite so clearly in the knee. And what I would say is due to the lumbar spine. Again, it's a little bit of a natural history going on here too, but I feel comfortable saying that this is a lumbar spine problem, mostly because I can piece it together with what I see in the clinic, what I've seen with past patients, and I have a strong inkling that if I had her flex her lumbar spine or go sit on that sinky couch for 8 hours, I feel like I could reverse the gains. So reproducibility, can you see this with lots of patients or with the same patient? And reversibility are 2 criteria for how you can kind of prove if your theory is right. Is this getting better because of the lumbar extension or any intervention that we did? Or is it getting better just because of time, right? So reproducibility and reversibility, things we can use if we need to. I'm not gonna have her flex just to make that point. She was happy with care, I was happy with care. And yeah, if you have questions, please let me know. If I left something out that's important, let me know and I'll try to answer those.